So I'm talking about Back to the Future, and I'll explain that shortly. So this is what I'm talking about: statistics, how we die, palliative care. I'm going to tell you the story of Millie and the Lancet, and why my talk is called Back to the Future. So death in Australia in 100 years ago, 100 years or so ago. We died of things like pneumonia, TB, diarrhea, infectious diseases, essentially, heart disease and stroke. 25% of us would have died before the age of 5. 25%. Life expectancy was mid-50s, and if we were very ill, we'd call a doctor or a priest, and we would have died at home in familiar surroundings, as Samar and Stephen have already said. 100 years later, so there are about 200,000 deaths per annum in Australia, and that's going up every year. It went up 20,000 last year because the population is getting older. Heart disease, dementia, COVID-19, strokes, lung cancer. Dementia first came into that top 5 in 2006, and it's gone to number 2 in that short period of time, and soon it'll be number 1. COVID-19 is an anomaly because that's the first time an infectious disease has been in the top 5 since the late 60s, when there was influenza epidemic. There were 958 infant deaths in 2022, which is a vast difference from 25% of us dying before the age of 5, I beg your pardon. And Spanish flu killed over 30 million people, and COVID-19, the estimates are very rough, but thought to be in the region of 7 million. So what we die of now is basically prolonged illness in many respects, or prolonged disability. So life expectancy is now in our 80s, and our place of death is very, very different. And slides are available, so you don't need to copy. If you'd like me in the slide while you're taking photographs, I'm very happy to do that. Place of death is hospital 50%, nursing homes 36%, home 14%. We don't die at home anymore. We die in a healthcare facility. It's different for First Nations people. Very different. 15,000 deaths per annum. Cancer and heart disease, 23% each. Life expectancy, 70s. That's life expectancy, not average lifespan. And it's a lot lower for people in rural and remote communities. And that's a shocking statistic. The top 5 diseases that cause significant burden for First Nations people: mental health and substance use, injuries, heart disease, cancer, and musculoskeletal disease. So different pattern of diseases, different group of diseases. How people die. So goal number 4 on our list of aspirations is about education and teaching and learning from each other. And when I first did a community health forum, not community health, it was really, I did run a forum for the community about how we die in Australia, to try and, I was just about to use the word empower, but I won't, but try and help people in the community understand what healthcare does and doesn't have to offer. And we die differently. And so I said to this group of community members, this was in Byron Bay where I used to live, how people die is there are different categories of death. And it's the first time I've been heckled. And this woman at the back said, "You can't put dead people in a box." What do I do with that? You know, so, but actually we do die differently. We do die in different ways. So on the top left here, sudden death, sudden death, like a gunshot or an accident. On the top right, so this is on the vertical is level of function, along the horizontal is time. So sudden illness, that used to be cancer. It still is cancer for very treatment-resistant disease. But, you know, you'd have a period where you'd have diagnosis and a predictable period where you would die. What happens for most of us now is this. that you have a chronic disease, including cancer in most of the cases, where you will be traveling along and then you have an acute exacerbation of illness. You become suddenly unwell. You might have to go to hospital. You might be able to stay at home, depending on your compassionate community, depending on the resources that you have available to you. But you will continue to have these acute exacerbations of illness, and at some point during that, you will die. So there's a predictable component to it, but it can also sort of be unpredictable as well. And then finally, in dementia and frailty of old age, and frailty is a medical term, there's this chronic sort of slow decline in function and health, and then people die at the end of it. So medicine through the ages has been about to cure sometimes, to relieve often, to comfort always. That's been the case for thousands of years, until probably the last 100 years, where now we're very, very, very much focused on cure. So I'd like to think in palliative care, I'm a palliative care doctor, I'd like to think that we are involved with patients who are cured sometimes, that we do relieve often, and that we comfort always. You're not going to get comfort from a healthcare system necessarily. That's the structure and the function of healthcare is about disease, but people have illness, and they're not the same thing. So that a lot happened in the 1960s. We had feminism, we had black power, anti-war movement, human rights, patients' rights. Lots of things were happening in the 60s. And one of the great components of modern palliative care is, of course, Dame Cicely Saunders, who is the founder of the modern palliative care movement. She saw that cancer patients were being pushed aside. She saw that cancer patients were being disrespected and being ignored because they were seen as a medical failure. And she said, this is not okay, that people matter, you matter because you are you. And that she was very stringent. She was a nurse first, then a social worker, I believe, and then a doctor. It was only as a doctor that she had some voice, but she really understood that death was not just some sort of medical failure. Elizabeth Kubler-Ross, again, another formidable woman, just like Summer. All the formidable women seem to be attracted to end-of-life work, and it's Elizabeth Kubler-Ross, again, another pioneer in her field, talked about death and dying, talked about the process of grieving, and really started to put language around something which had been removed from the community. And then Louis Kuttner, who is an American and a lawyer, and he basically understood that with medicine had become very high-tech, low-touch, whereas it had been high-touch, low-tech, and realized that, yes, people were living longer, but we were now in the process of prolonging death and prolonging dying, and he wanted to write down a document that prevented people from overriding his wishes, and that's when the first Advanced Healthcare Directive came in. So palliative care, and we're getting tripped up with language like end-of-life care and palliative care, and what are this, last days of life. Palliative care is a broad term. For me, it's a philosophy about acknowledging that someone has an incurable disease, and the energy goes into making people feel as well as possible for as long as possible, which does also include having treatment. It's not either or. And I've wondered about writing the word language I should use here. And complex, if you're a patient and you have advanced cancer and you have terrible pain issues, for example, then you might need to see a specialist palliative care provider. But you're going to be at the top of that triangle, which is the small percentage of people who have needs that require specialist palliative care involvement. If you're in the middle, then you may have pain or symptom issues. You may need to see a specialist palliative care health worker and then not back to your GP. Or you're, and I've used the word normal here, and it was really an inspiration from Stephen. I was going to say less complex, but actually normal's a better word. For most of us, we may not need to see a specialist palliative care provider at all. That our death trajectory might be very, very uncomplicated and much more reliant on social input and social connection rather than medical connection. As Professor Keller has said, 95% of our time is with our families rather than with a healthcare provider. And healthcare is very much dependent on meeting needs, whereas compassionate communities is very much dependent on looking at assets in the community and building from there. So again, when I did that forum, I devised this diagram, and then which has sort of evolved over time. And this was really about education and development in the community. And it was really to try and explain to people, when we talk about palliative care, everybody immediately goes to death. When you talk about end-of-life care, everybody goes to death. And then it cuts everything off because they retreat. Quite rightly, death is very scary. Inherently, how we've been taught, how we've been socialized, that death is something to be feared and something to be avoided. But there are many, many aspects of dying that can be approached and appreciated. So, wellness and illness, increasing decline, dying, death. In between, like post-death, pre-ceremony, you can have a body at home for a period of time. People don't know that. At ceremony, disposal, there isn't a kinder word, and if someone can come up with one, I'd be very grateful. And bereavement. And then there's all these spheres that influence that journey. I don't use the word journey very often. I don't know why I did then, but this spectrum of what's known and what is expected in our demise, then there are multiple areas of influence in this. If it's just the healthcare system, you're not necessarily going to get all of the spectrum that's available to you. You might not pay attention to, or your cultural beliefs might not be paid attention to, your family might not be involved in your care. As we're saying that death isn't a medical event, it's a human event, it's a relational event, it's a sociological event, it's a natural event, it's not even human, it's nature. But what's really important here is knowledge. That hasn't come up very clearly. So knowledge, what I'm trying to give you is what I understand about death and dying in Australia at the moment, sharing what you're giving to compassionate communities when you fill in your survey. But probably the bigger thing here is influence. We need knowledge, but we need to share it. There's no point us having it and keeping it. We need to share it, and we need to have influence. Influence to people who don't even know that they need support yet. So that's just a nice conceptual diagram to look at death and dying in Australia. Millie. Sorry. This is Millie. Millie's 23 years old, and Millie is beautiful. And Millie is trying to live while she's dying. She has a very aggressive, untreatable cancer that the health service could only meet with an apology, really, a mumbled apology at that. I'm showing Millie's smile because I want to maintain her privacy, and that's Zeus, who came to visit us on the palliative care ward several times during her stay with us. And when I first met Millie, she was very, very sick, and we thought she was going to die. She spent a fair amount of time with us because she has very complicated pain, mobility issues, and everything that you would expect that a 23-year-old would have when they're having to face their own mortality. And she felt very safe in hospital, but she wanted to go home one last time. When she was diagnosed, the community that she lived in, within 2 hours, raised $21,000 on a GoFundMe page. She does not come from a wealthy community. And this all happened at a local restaurant, her favorite restaurant. And so there were people there that she knew and she didn't know. And when she went home from the palliative care wards to go back to her home for a short period of time, we'd organised a nurse to go and stay overnight to some support for the family. And we managed to get the funding, which was amazing, but we couldn't get the nurse. The nurse wasn't available. So a family friend who was a nurse, who wasn't a palliative care nurse, just put her hand up and said, yes, I'll stay the night. And it made a massive difference for the safety and the just the reassurance for that family that she was able to go home knowing there was someone else there. And then during her time on the ward, Ambulance Wish came and they provided a 3-course gourmet meal because Millie's a chef, because Millie wasn't able to go out to a restaurant. And just, so the reason I'm telling you this is because there isn't a compassionate community per se there, but there is a compassionate community there. And when people hear about someone else's demise, they put their hand up, they want to stand up, they want to be better, they want to contribute, they want to be bigger. It's hard sometimes in this world to find an opportunity to be your better self. So just as I'm coming to a close, I just want to talk about this document, and it was in the Lancet Commission in 2022, The Value of Death and Bringing Death Back into Life. And this is a bit where Back to the Future comes in, because we used to care for the dying at home and haven't, and the future has got to be caring for people at home. This document, I would strongly encourage you to read it. It is 46 pages long, so you might need to dip in and out of it, but it does not pull its punches. And basically, sorry, the computer's just playing up. Basically, without death, there is no life. Without life, there is no death. They were dependent on each other. And death gives life meaning. There's a quote, I have a rendezvous with death at some disputed barricade, and we're probably the only creatures on the planet who understand that they're going to die and are able to plan for it, and yet, strangely, we don't. And we really, in the value of death, must stop thinking about death as a zero-sum game. Sorry, it's not working. No, oh, I got it back. Thanks, thank you. And it basically says healthcare has failed the dying, which I think is absolutely right. That palliative care improves quality of life, symptom burden, and is cost neutral, cost effective, and cost saving. So I think palliative care services within the health services, we're a bit like compassionate communities in the community. We're trying to do our best for the dying, but it's very, very hard to attract funding in a palliative care service. And it talked about the 5 principles for a realistic utopia. The social determinants of death, grieving, and dying are tackled. Dying is understood spiritual and relational process rather than a physiological event. Networks of care lead, support, and for people who are dying, caring, and grieving. Conversations and stories about everyday death, dying, grief become common, and death is recognized as having value. Because I say it allows people to step up, grow, and be part of something bigger. So having gone through those, the Back to the Future, the future is that we embrace death and dying back into the community where it always was, and it always is, and for many cultures, this is quite a Western philosophy of pushing the dead and the dying to the outskirts. But with us together, we are us, you, me, we. The future is to reclaim that death and dying for the future. And I'll be doing myself out of a job, which is probably a good thing. So thank you very much for listening.